Okay. Okay. Good morning, everybody. Thank you for joining us. Today we have a little different twist on the lecture series. We're going to be talking about inverting papilloma. For those of you who are specifically interested in rhinology, I'd like to introduce to you Dr. Kevin Hur. He is on faculty at University of Southern California School of Medicine. He attended college at Johns Hopkins. He attended medical school at University of Southern California, and he did a fellowship in rhinology in Chicago at Northwestern University. Really, there's really little much more to say other than we should have a really nice lecture today about a topic that all ENT should know about because it's not that unusual of a pathology. Okay, so with that said, Kevin, thank you for joining us, and please take over.
All right, thank you. Can you guys hear me okay?
I'm good here. Nestor, you okay?
Yes, Richard, I hear.
Okay, so we're good to
Loud
go.
and clear.
All right, sounds great. So my name is Kevin Hur. I'm assistant professor in the Division of Rhinology and Anterior Skull-Based Surgery here at University of Southern California in Los Angeles. I want to thank Richard for inviting me to talk today. So I'm going to go through sort of like there it goes. I have no financial disclosures. So I'm going to talk about the epidemiology, the clinical presentation, the etiology, and the management of inverted papilloma in terms of what we do today and as rhinologists, well, at least how I manage them today. And I'm happy to have an open discussion. So anytime during the presentation, if you have any questions, feel free to interrupt me. So inverted papilloma is the second most common benign sinonasal tumor after osteoma. It arises from the sinonasal mucosa. There are three subtypes. There's inverted, which is the most common. It makes about 70% of the sinonasal papillomas, followed by exophytic or fungiform, as well as oncocytic, which is more rare. So even though it's the second most common benign sinonasal tumor, it only makes up less than 5% of all surgically removed nasal tumors. And it usually presents unilaterally, but it can also present bilaterally. In this photo on the right here, you can see it has sort of this wrinkled appearance, and there's a picture of an inverted papilloma in the nasal cavity. So what makes inverted papilloma unique? So it has three main interesting characteristics. One, it has a high tendency to recur. It has also destructive or bone remodeling capacity. And the most concerning feature of inverted papilloma is that it's associated with sinonasal malignancy in about 10% of inverted papillomas, the most common being squamous cell carcinoma. And so this is the characteristic that sort of makes surgeons more aggressive in terms of resection, because 10% of these inverted papillomas have been known to harbor malignant features. So in terms of the epidemiology, the incidence is 0.74 per 100,000 per year. It's more commonly seen in men and more commonly presents in the 5th to 6th decade of life. In the nasal cavity, the tumor oftentimes originates from the lateral nasal wall, followed by the maxillary sinus and the ethmoid sinus. It can originate from the frontal sinus or sphenoid sinus, but that's more rare. And these are for inverted papillomas that have a very easily determined site of attachment. There are some times where it has a very diffuse attachment where it's attached to multiple locations. That's also a possibility as well. And those tumors are obviously harder to resect because they're attached to multiple areas. So what do patients usually present with? The most common clinical presentation is a patient will come to you and complain about unilateral nasal obstruction or watery rhinorrhea. More rarely do they present with epistaxis. It's possible, but it's more uncommon. I haven't seen that before. If they also complain about epiphora, proptosis, diplopia, or headache, then you become more concerned that this is an advanced lesion that's involving the orbit or the skull base. And so during the diagnostic workup, nasal endoscopy should be performed. And during the nasal endoscopy, it's important to sort of determine whether or not you can identify the site of attachment. And sometimes it's very difficult because it's a very bulky mass. And so sometimes you have to use imaging to identify those areas. And usually the papilloma presents as like a pink, tan, or gray, non-translucent polypoid growth with a wrinkled surface. And I think that picture on the right is a good example. Some unique features that you can see on CT or MRI for these masses is CT you can see hyperostosis, which is bony growth. And I'll have an example of that on the following slide, as well as osteitis. Now, on MRI, a unique feature of the inverted papilloma is something called the convoluted cerebriform pattern. And I'll talk about that later. But the gold standard for diagnosing inverted papilloma is a biopsy, but with histological confirmation. So on histology, inverted papilloma is characterized by these, as you can see here, these hyperplastic ribbons of basement membrane that envelops this epithelium. So epithelium can be respiratory, squamous, or transitional, or a combination of the three. And this epithelium basically extends into the underlying stroma here. And so the inverted papilloma is basically known for having these ribbons, and in the United States here, we sort of see these on our board exams. So in the coronal CT scan, this is a typical presentation of inverted papilloma. We see here's the mass in the right maxillary sinus that's extending into the nasal cavity here. You see there's destruction of or obliteration of the medial maxillary wall here. And then what's interesting about this one is you can see that there's this bony sclerotic spicule here. And this is an example of hyperostosis. And when you see this on a scan, this is most likely where the site of attachment is for the inverted papilloma. And so CT scans are very good for identifying or defining the extent of disease of inverted papilloma, but sometimes it overestimates the extent of disease because it can't distinguish between the inflammatory component versus the tumor itself. So this is an example of MRI. So this MRI demonstrates the cerebriform columnar pattern, which you can see here by the alternating roughly parallel lines of high and low signal intensities pointed out by these black arrows. And that basically reflects the alternation of the highly cellular metaplastic epithelium with the underlying stroma. So MRI is very good for evaluating the extent of disease, whether or not there's invasion of the orbit or the skull base. And this scan, this is a T1 enhanced axial MRI. You can see there's a mass in the right maxillary sinus extending into the right nasal cavity here through the accessory ostium. So what causes, why do inverted papillomas develop? So there's been several proposed theories, but there hasn't been much agreement as to how inverted papillomas develop. And so I'll briefly discuss, the three main theories that have been proposed for inverted papillomas. And they are viral infection, chronic inflammation, as well as possible environmental exposure to pollutants or similar environmental pollutants. And so the presence of HPV DNA in cyanidosal papilloma was first reported in the 1980s. And since then, there have been several studies to perform that have tried to identify HPV DNA in inverted papilloma specimens, but the results have varied widely. And so some studies report 0% HPV DNA in inverted papilloma specimens, while some report all their specimens had HPV DNA. The most commonly reported subtypes are 6, 11, 16, and 18. And the reason HPV has been suggested as a possible factor in the development of inverted papilloma is that some believe that HPV may be an inducing or promoting agent in the pathogenesis of disease that leads to alteration in the gene P53, but the association is unclear. And also because inverted papilloma is associated with squamous cell carcinoma, that's why there's been some talk, and that's why there was a lot of interest in looking at HPV DNA in inverted papilloma. But the results have been mixed in terms of whether or not HPV is truly associated with the development of inverted papilloma. Others have suggested that inverted papilloma is the end stage of a chronic inflammatory condition rather than a true neoplasm. Dr. Lanza and colleagues at UPenn found that inflammatory cells were significantly more common in inverted papilloma compared to other cyanidosal papillomas in the study, which you see in this table. Inflammatory cells are much higher compared to the other cyanidosal papilloma types. And so their theory was that inverted papilloma evolves histologically in a stepwise series where respiratory epithelium is replaced by inverting squamous metaplasia, which can then develop dysplasia, which can then eventually progress to squamous cell carcinoma. But only this group has been studying chronic inflammation as a possible etiology, and I haven't seen any other studies that have suggested that inflammation may be associated with inverted papilloma. The role of environmental pollutants has also been discussed, although is also controversial. They're mostly been case control studies. And so this one study from 1996 found a higher degree of occupational exposure to smokes, dust, and aerosols in the inverted papilloma group compared to the control group in this study. Another study done in 2010 by Sham and colleagues found that outdoor and industrial exposures were significant risk factors for the development of inverted papilloma compared to those who were not exposed to those pollutants. And this was after controlling for alcohol, allergic rhinitis, sinusitis, nasal polyps, etc. And so environmental exposure may have some component towards the development of inverted papilloma, but it's still unclear. So what are the risk factors for recurrence, which is one of the most concerning characteristics of inverted papilloma? And so based on previous studies, the most important factor is determining the location of attachment and the completeness of resection in the primary surgical resection. So one retrospective study of 121 cases, which you see here, found that the recurrence rate was 18.1% in revision cases versus 4.1% in primary cases. And that's actually due to the increased difficulty in revision cases to identify the site of attachment because it's complicated by scar tissue, the absence of bony landmarks, and also there might be residual disease in different locations, not just the primary site. And so it's very important that during the primary surgical resection, the entire tumor is removed. And so does location matter in terms of whether or not there is recurrence of inverted papilloma? And so Sitardi and colleagues at the Cleveland Clinic analyzed about other cases from 1985 to 2006 and stratified them based on where they were located. And what they found was that in group A, which is here, I mean, those tumors that are confined to the nasal cavity, ethmoid sinuses, or the medial maxillary wall, their recurrence rate was about 3%. Whereas tumors that involve any of the maxillary wall, or frontal sinus, or sphenoid sinus, the recurrence rate was about 19.8%. And then in inverted papillomas that extended beyond the paranasal sinuses, the recurrence rate was 35.3%. And so this can be interpreted that aggressive disease is related to location, or that aggressive tumors tend to spread to group B or C areas. So the larger the tumor, the higher risk of recurrence. All right, what about the surgical technique? Is there an optimal treatment for inverted papilloma during the resection? And so recurrence is sometimes attributed to incomplete resection. And so this study out of Mass Eye looked at whether or not surgical technique impacted recurrence of inverted papilloma following endoscopic excision. So they performed a retrospective review of 127 patients at their institution and found that drilling, cauterizing, or removing bone at the tumor base significantly reduced the tumor recurrence compared to just mucosal stripping. And so the likely reason is that inverted papilloma tends to have frank tumor that's embedded into the bone that cannot be removed just with mucosal stripping alone. And so this was confirmed by a group at UPenn, where they resected 1 to 2 centimeter wedges of bone with overlying inverted papilloma tumor in block and examined them under light microscopy. And they found that the bony surface underlying inverted papilloma was irregular with little crevices. And so you can see these black arrows are pointing towards little crevices in the bone where mucosa is trapped, right? And so that reaffirms the importance of drilling the bone where the site of attachment is. Otherwise, tumor will be left behind, embedded within the bone. So what's the relationship between inverted papilloma and squamous cell carcinoma? So most of the textbooks will say that around 10% of inverted papilloma is associated with malignancy. And there was a large study that reviewed about 2,297 cases of inverted papilloma, and that's where that 10% prevalence or association with malignancy comes from. In that study, they found that 7.1% of inverted papillomas had diagnosed with carcinoma that was already in the initial lesion resected. So someone removed inverted papilloma and they found that there was evidence of squamous cell carcinoma within that specimen. Whereas 3.6% have carcinoma that appears to be an area that was removed earlier. And the mean time to transformation in those specimens, those patients in which they were followed, the mean follow-up was 52 months, with that range from 6 to 180 months. And so that's why we recommend in patients that had inverted papilloma resected that there's surveillance that's performed annually at least for several years to monitor for the possibility of carcinoma developing. So how do we manage inverted papilloma? So the way we manage inverted papilloma surgically has evolved over the years. Transnasal resection without endoscopes was the initial method of choice, but that had a recurrence of 40 to 78%. That was mostly done in the 1970s and 80s. The gold standard treatment for inverted papilloma was the medial maxillectomy, which became more popular in the 90s. And that usually involved a lateral rhinotomy with medial maxillectomy or sublabial degloving with a medial maxillectomy. But the introduction of endoscopic techniques in the 1990s sort of revolutionized the treatment of inverted papilloma because it had the advantage of performing surgery with the absence of a facial incision. There was negligible facial swelling, shorter inpatient time, reduction in postoperative pain. And so a systematic review performed in 2006 by a group at Stanford found that the treatment of inverted papilloma endoscopically has significant lower recurrence than non-endoscopically treated patients. And so patients that had endoscopic resection, the recurrence rate was 12%, whereas those that had open approach, it was 20%. And so since then, the majority of inverted papillomas are managed endoscopically with large tumors, except for large tumors, which tend to need an open approach to resect those tumors. And so one of the most
Excuse me, Dr. Kevin.
Yeah.
I'm Nestor from Paraguay. You were talking about the surgery, and I want to ask you about, do you manage the inverted papilloma fully by endoscopic surgery? Or
yeah,
do you have sometimes to combine it with an open approach and endoscopy as well?
Yeah, so usually for combined approaches, it's usually tumors that are usually in the frontal sinus and very lateral, so over the orbit. In those patients, it's very hard endoscopically to reach those areas. But in almost any other case, I can remove inverted papilloma endoscopically. I'd say it's usually only those cases where it's in the far lateral aspect of the frontal sinus over the orbit where I usually have to do a combined approach, an open and an endoscopic approach to resect the entire tumor.
Okay, thank you, doctor.
Yeah, no problem. So one of the most common surgical approaches for resecting inverted papilloma extending or originating from the maxillary sinus is the endoscopic medial maxillectomy, which allows visualization and access to the maxillary sinus. And so I'm just going to go over the technique that I use to perform an endoscopic medial maxillectomy. And I usually basically follow the technique from this atlas of endoscopic science and skull-based surgery that the rhinologist at UPenn published. Basically, you first perform a maxillary enterostomy, enlarge the maxillary enterostomy posteriorly until the posterior wall of the sinus is encountered. You then remove the inferior turbinate. So I crush it first. You can see in this first photo, you crush it with a tonsil, and then you resect inferior turbinate back to the posterior maxillary wall. Usually leave a little stump of the inferior turbinate here, and we cauterize that. And then after the inferior turbinate is removed, I usually raise a mucosal flap. So I make a cut using a keratome, which is an ophthalmic knife, along parallel to the posterior maxillary wall. And then you make another cut right posterior, this Hasner's valve here. You make the posterior cut right behind Hasner's valve. And then you elevate that mucosal flap and lay it against the septum. So you can see here, we're elevating the mucosal flap, and then you lay the mucosal flap against the septum. And that exposes the bony medial maxillary wall here, and we just drill all this away. Once you drill out this entire wall, then you have direct visualization into most of the maxillary sinus. And then you can also use a backbiter and go underneath the Hasner's valve here. You can also remove this bone here as far anteriorly as you can until you hit the anterior maxillary wall. And after the entire medial maxillary wall is drilled away, we lay our mucosal flap back down to cover the exposed bone, and it tends to heal very nicely postoperatively. But the one downside of the medial maxillectomy, it doesn't always allow you access to the anterior maxillary wall because the nasolacrimal duct is right here. right? And so it prevents you from actually seeing the anterior part, but it lets you have a good visualization of the posterior wall as well as the lateral maxillary wall. And so in the last couple of years, another approach to the anterior maxillary wall has been developed called the pre-lacrimal approach. And what that allows is you enter through the prelacrimal recess, which is the area right anterior to the nasolacrimal duct. And you're able to put a 0-degree scope through this opening, and you can access the entire anterior maxillary wall, because sometimes you'll have tumors that are attached to this area. So what that involves is you sort of make an incision. You make an incision anterior to the head of the inferior turbinate, elevate the mucosa, and you just drill away that bone while staying anterior to the nasolacrimal duct. And that small opening will allow you to access the anterior maxillary wall. So in this example here, there's some residual tumor located here. I can see on the CT scan on the right anterior maxillary wall, there's some residual tumor here. And so what the video is going to show is we're going to enter through this prelacrimal recess here to access the anterior maxillary wall to remove the mucosa. So you use a needlepoint bovie, make an incision anterior to the head of the inferior turbinate. And you can also make some releasing cuts posteriorly and superiorly there. Elevate the mucosa to expose the bone of the medial maxillary wall anteriorly. And you basically go posterior until you hit the nasolacrimal duct. And once the bone is adequately exposed, we can use a diamond burr to enter into the maxillary sinus, which you'll see in a few seconds here.
Dr. Kevin,
Yeah.
do you use a neuronasal navigator for these surgeries?
You can. You don't necessarily need to, but yeah, I usually do just because I teach residents and everything. So, so I try to show, you can use the navigation. What navigation is helpful for is identifying also where the nasolacrimal duct as well. But you don't have to use it for these maxillary for these surgeries, but it is helpful. Yeah.
That's why I'm asking, because I would like to know. I didn't hear if you say it already, but I would like to know, where is your landmark to do this incision in front of the nasolacrimal duct?
Yeah, so but the nasolacrimal duct, you can usually identify it with Hasner's valve. So sometimes I'll just lift up the inferior turbinate and you can identify Hasner's valve. If you have trouble seeing Hasner's valve, you can put some fluorescein in the eye and then press on it, and you'll see the green liquid come out through Hasner's valve below the inferior turbinate, and that's a real landmark that you don't want to go you don't want to go through that area anterior to it. But the navigation is useful, that you can use it to identify the nasolacrimal duct. You can also identify the piriform aperture. You can also palpate that pretty easily during the case. And those are your anterior and posterior landmarks.
Okay, thank you very much.
So once you open up this into the prelacrimal recess, you can see here with the 0-degree scope, you can see straight down the anterior wall of the maxillary sinus pretty easily. And then you can use your straight instruments to remove the mucosa in that area. So they're stripping the mucosa where the attachment of the tumor was. Now we have exposed bone of the anterior maxillary wall here. And then we're just gonna, just like that previous study, you have to either drill or bovie this area to get the embedded mucosa within the bone. And then there's plenty of some hemostasis here. And after you're done with after you remove the tumor, you can close this. You can put some interrupted sutures here. This is probably the hardest part of the case. Storing these sutures can be a little bit difficult. You don't want to have too much tension because otherwise they'll rip the mucosa. So you just want to put just bring the mucosa edges slightly together. It doesn't have to be too tight. And it tends to heal very nicely post-operatively. All right. Yeah, so even after a week, it tends to heal great. So those are the approaches that I think are available or that I consider whenever I'm trying to resect inverted papillomas from the maxillary sinus. So usually I use the medial maxillectomy approach to try to get tumors that are more posteriorly or laterally. And if I can't access the tumor in the anterior aspect of the maxillary sinus, then I usually consider the prelacrimal approach. All right, so now I'm going to talk about some of the challenges of resecting inverted papilloma. So frontal sinus inverted papilloma, which I think someone asked earlier, those are probably one of the more challenging areas to resect inverted papilloma endoscopically. And there have been some small studies looking at what are the recurrence rates for resecting inverted papilloma in the frontal sinus. So 1 to 16% inverted papillomas occur or originate from the frontal sinus. And surgical approaches oftentimes involve a modified Lothrop, which is an endoscopic approach to connect the two frontal sinuses versus an osteoplastic flap. So those are, like I said, tumors that are located or attached more laterally or to the superior wall of the frontal sinus. Those are probably better managed with the osteoplastic flap, while tumors that are located more inferomedially, an endoscopic approach using a modified Lothrop is feasible. And so there was a systematic review performed by the group at Stanford where they looked at 57 cases and 13 studies, and they found that the recurrence rate for inverted papilloma in the frontal sinus is 22.4%, which is much higher than other areas of the frontal of the perinasal sinuses. And there was no difference in recurrence between surgical approach. And it's most likely just because of the location that's attachment in the frontal sinus is just more difficult in general to access, that the recurrence rate is much higher. So like I mentioned earlier, there is the possibility of malignancy developing after resection of inverted papilloma, and there's also the high risk of recurrence after resection of inverted papilloma in general. So that's why frequent follow-up is very generally recommended. Monthly for the first year, every 2 to 3 months follow-up for the second year. And studies have shown that most recurrences occur within 2 years after surgery. And repeat imaging usually is not necessary because after surgery, all the anatomical barriers have been removed. And so just using an endoscope, you should be able to see all aspects of the perinasal sinuses in which the surgery was performed. And so imaging usually is not indicated unless there's some reason that you're not able to view the areas that you're trying to survey. So some of the challenging areas in resecting inverted papilloma are the sphenoid sinus if it's attached to the optic nerve or carotid artery, or if there's intracranial extension, or if it invades the orbit. And so, not surprisingly, studies have shown that attachment over the optic nerve or carotid artery is associated with a 4.76 greater rate of recurrence compared to other sites. And that's most likely because there's some vagination of the tumor into the bone overlying the carotid artery optic nerve. And like we mentioned earlier, you have to cauterize or remove the bone in that area or drill the bone in that area in order to have technically a complete resection. Just stripping the mucosa is not good enough. But obviously, this is not a malignant tumor. It's a benign tumor that has a high rate of recurrence. And so I'm sure most surgeons, when they see that there's tumor attached to the optic nerve carotid artery, the possible morbidity of removing bone of that area is much higher if you have to remove the bone. And so most people probably will just strip the mucosa and survey that area rather than being a cavalier and removing the bone and risking any type of injury to the optic nerve or carotid artery. In terms of intracranial extension, it's very rare, but there have been reported cases of benign inverted papilloma extending into the intracranially. In general, this is a case series of 17 patients that found that patients with intracranial extension were more likely to have recurrent disease, and invasion was commonly through the frontal sinus or cribriform plate. Any dural disease had a poor prognosis with only a 25% survival. But there was 100% survival if the tumor was extradural, which makes sense. In terms of orbital invasion, there's only been one small case series of 10 patients that had inverted papilloma orbital invasion. All those tumors had evidence of malignant transformation. So if you see if you biopsy a tumor that comes back as inverted papilloma but it's invading into the orbit, that's most likely has already transformed into a malignancy. 80% of those patients had an orbital exenteration, 80% of those patients had recurrence, and 30% had intracranial invasion. Radiation therapy as a possible treatment modality, there's been very limited data, but it can be considered an unresectable inverted papilloma, those that had a subtotal resection, and those patients that have had multiple recurrences. And so there was a literature review done in 2012 that looked at 17 patients in the literature that received radiation therapy. Those that had surgery with no residual tumor after resection that received radiation, of those 9 patients, 11% had a recurrence. And those that had surgery, but there was macroscopic residual tumor left behind. In those 5 patients, 20% had a recurrence after radiation therapy. And those 3 patients that had radiation therapy as a primary treatment modality, 2/3 of those had a recurrence. And so there's very little literature in terms of the use of radiation in inverted papilloma. This is basically all we have. But it is a possibility, especially in those patients that have unresectable inverted papilloma or those that had subtotal resection. So I probably recommend that try to do a debulking as much as you can of the inverted papilloma, and whatever is left behind can be radiated. In terms of medical treatment, there have been no reports of medical therapies used primarily for the treatment of inverted papilloma, but there have been studies looking at adjuvant medical therapies for the treatment of inverted papilloma. So 5-FU has been proposed as an adjuvant treatment post-op. It's a structural thymidine analog that interferes with DNA synthesis, oftentimes used to treat epithelial malignancies by acting on proliferating cells. And so in this study, after resection of the inverted papilloma that was attached to the skull base, they took some mirror cells and put some 5-FU on those mirror cells and had those pressed against the skull base. And they found that there was only a 5.6% recurrence rate in those patients, basically 1 out of 18 cases, in those patients that received 5-FU adjuvantly after the surgery. There's the follow-up for that study was about 45 months, so basically about 4 years. Another study that looked at possible adjuvant therapy for inverted papillomas was looking at COX-2 receptors on inverted papillomas. And so what they found was that 61% of inverted papillomas stained positive for COX-2. So COX-2 is a common, is a rate-limiting enzyme that's known to contribute to some head and neck cancers. And so if there are a lot of COX-2 receptors on inverted papillomas, then it's a possible therapeutic target for patients with unresectable IP. You can try to do a debulking and then give a COX-2 inhibitor afterwards. But there haven't been any studies that have performed that. All we know is that 61% inverted papilloma specimens have COX-2 receptors on them. Whether or not COX-2 inhibitors will affect their growth or prevent recurrence is still unclear. So in conclusion, the etiology of inverted papillomas is still unclear. Risk factors for malignant transformation have not been identified. Careful evaluation of the attachment site and complete resection is essential to prevent recurrence afterwards. And obviously, recurrent tumors are harder to resect because it's harder to identify the attachment site now that surgery has been performed due to scarring, etc. The surgical approach has evolved over the years from a transnasal approach to an open approach and now to endoscopic approach with decreasing recurrence rates with each new technique. And the 5-FU and COX-2 inhibitors are being investigated as possible adjuvant medical options in the treatment of inverted papillomas that are unresectable or attached to areas that can have high morbidity, such as the carotid artery or the optic nerve or to the orbit. Thank you guys for inviting me. Does anyone have any other questions?
Kevin, thank you very much for very informative and up-to-date. When I trained, we were doing lateral rhinotomy and medial maxillectomy for this disease. Things have changed. Fortunately, it's a much more cosmetically acceptable approach when you do it endoscopically. Anybody have any further questions? It's interesting about these, receptors, the COX receptor. Anyway,
there is a question that they wrote to you on the chat, at the chat.
Oh, there is? How do I?
There's a question. Where is that question? Nestor, can you read it to us? I can't see it.
Yeah, I can't. Someone can read it to me. That'd be great.
Yes, this is from Manuela Orduz,
Okay.
and she says, who has knowledge on this pathology in exclusive affectation of the middle ear and mastoids?
Wait, say that again. I didn't catch the last part.
Okay. 1 second, please. If any of you have knowledge on this pathology in exclusive affectation of the middle ear and mastoids.
Oh, I don't know. Yeah, I'm not sure. I don't think I've ever heard of inverted papilloma. I'm sure it must be possible, but I haven't heard of inverted papilloma in the middle ear or mastoid. I don't know if Dr. Wagner.
Yeah, the only
that
thing is the external ear canal. I've seen condyloma, which are, papillomas of condyloma acuminata, which is a venereal wart, just like vaginal condylomas. But I've not seen it in the middle ear. Got to be you got to be careful with middle ear disease, especially because you can get granulation tissue in the middle ear. If you have a perforated eardrum and you have pathology in the ear canal, it could go into the middle ear potentially. But an isolated papilloma of the middle ear, I do not know of any. But I think that's a very good question, and I'll do a little lookup on that, and I'll get back to you on WhatsApp platform, okay, to see if there's any reported cases of any type of papilloma with normal tympanic membrane in the middle ear. Okay, thank you for the good question.
I have one question about practical use of COX-2 inhibitors. It is nowadays just used just now or just in some investigations?
it's still under.
Go ahead.
Still
Let her identify herself, okay, so you know who you're talking to.
Agata from Poland.
Okay, thank you.
Hi, Agata. Yeah, COX-2, that's just still being studied, still under investigation. All they have determined so far is that there are COX-2 receptors on papillomas. Not all of them, only 61%. Why some of them have receptors and some don't, we still don't know. And whether or not COX-2 inhibitors will have any effect on inverted papilloma, that's still being investigated. So I wouldn't give COX-2 inhibitors to patients with inverted papilloma at this time. It's still something that I just brought it up because I think it's something that people are investigating as possible medical treatments for inverted papilloma, but it hasn't been. I wouldn't use that.
Terry, you have a question?
No question.
I also have one question for Dr. Kevin. My name is Ostap. I'm from Ukraine. And my question, is there any correlation between the size of the inverted papilloma and the chance of having a malignancy on the biopsy or after the removal of the papilloma?
Yeah, it's a very good, Ostap, that's a very good question. So there is association between the size and recurrence of inverted papilloma, but there hasn't been any studies that showed association between the size and associated with malignancy. So how big it is, it doesn't not necessarily correlate with whether or not it's a malignant. It will have a focus of malignancy. But if it does invade the orbit or intracranially, or I think more the orbit, then I think there is a very high association with malignancy. But if it's just a big tumor that's involving all the paranasal sinuses, there has not been any study that I've seen that has shown that there's association between the size of those type of tumors and malignancy. But it is higher risk of recurrence the larger the tumor is.
Thank you. And is there any other malignant tumors of the nasal cavity that, except the squamous cell carcinoma, that can be associated with inverted papilloma?
Yeah, there is. I think I don't know when it's truly associated. That's the thing. Like I think squamous cell carcinoma by far is the most common. That's why people looked at whether or not HPV was associated with developing inverted papillomas. There have been reports of all types of tumors, like adenoid cystic. There was one like amyloblastoma. There have been like various, case reports here and there of all types of tumors that have been found with inverted papilloma. But those are so rare, like whether or not they're truly associated or not, I think that's unclear. I think for squamous cell, I think for sure, because of how high the prevalence is in terms of association with inverted papilloma. But all of the other tumors that you hear about, like, adenoid cystic or adenocarcinoma, all of those there have been case reports of inverted papilloma with those tumors. Whether or not there truly is association, I think I doubt that because of how rare we hear about it.
Thank you.
Hi, I'm Gustavo from Guatemala. Two questions, basically. For the patients that you usually go and operate and they have like a non-resectable tumor, or you know that you're going to leave behind some of the tumor, what's your favorite approach? Would you go radiotherapy in them? And for patients that have a recurrence, do you prefer to go in and drill the bone? Do you prefer to go in and just cauterize the bone, or do you prefer and give radiotherapy to them as well?
I try to avoid radiotherapy. I think as long as I can access the tumor and the site of attachment, I usually will drill the bone. I usually don't cauterize as much. If I can drill the bone, I will drill. If I can't drill it, then I will cauterize it. And usually, because it's a benign tumor, unless it's causing some type of, I usually don't give radiation. Usually I will just survey them afterwards. So my goal during endoscopic surgery is to expose everything so I can access it afterwards in the clinic to survey the patient. And I'll take out as much tumor as I can, and then I will strip the mucosa, and then I'll drill it if it's safe to drill that area and thin the bone out, and then I'll just wash them afterwards. And I think generally that's a good approach, because this is not a malignant tumor. I don't think it's worth the risk of causing any type of morbidity for the patient with radiation or other types of treatment that can have high morbidity. So I usually just strip the mucosa, drill it. If I can't drill it, I'll cauterize it, and I'll just wash them afterwards. Generally, I feel like in those patients, they tend to do very well. And that's like as a primary surgical resection. The harder patients are those that get sent to you who already had like 2 or 3 surgeries. Those are the more difficult ones, because you have to strip everything and drill all sorts of places, because you're not sure where the attachment site is anymore because of all the scarring from previous surgery.
Mm-hmm. Okay.
Thank you, Gustav. Okay.
Hi, I'm Manuela from Colombia.
Hi, Manola.
My question is because I have a patient. She's 44 years old with an expansive injury in muscle ear that pressures in the external ear conduct with fast and accelerated growing. We do it 2 surgeries and biopsy, and the pathology is papilloma inverted. So I ask if anyone has knowledge of this strange pathology in the middle ear.
Yeah, I am not aware of it, Manuela, personally, but you have an inverted papilloma of the external ear canal.
Yeah.
Okay, yeah. I don't know of, and the tympanic membrane's intact on the patient, I'm assuming.
Yeah.
Okay, yeah. Let me look that up, and I will respond to you guys on WhatsApp. Other than the condyloma, which is a venereal wart, which is a papilloma, and in your description of the inverting papilloma of the external ear canal, I will research that and get back to you guys. Okay, so be patient.
Thanks for your help.
Mm-hmm. Any other questions for Kevin? Well, if there's no further questions, I want to thank you, Kevin. You had a significant amount of questions. We appreciate your time and an opportunity to join with you. Just to let you all know, Dr. Monfred's going to be talking this Friday. I'll send you guys a link, and tomorrow I'll send you a notice. So again, Kevin, thank you very much. Hope everything's good in LA, and thank you everybody for joining. If there's no further comments. Okay, I'm going to end the session again. Thanks everybody for joining today.
All right, take care.
Thanks, Kevin.